Yes, sir, we got it. You have to make it full screen. Yes.
Yeah, and am I audible also?
Yes, very much.
Yeah, sorry about this delay. Uh, Yesterday's rehearsal went well. I don't know, something not very savvy with technology probably. Anyway, because of paucity of time, let me indulge in the talk straight away, but not before thanking Dr. S.K. Pal, who is one of the most cerebral brains on PCNL. That is my description about him. He has this entire art of PCNL in each and every DNA of his cells. And apart from the fact that he does good PCNL, he is a good teacher also. We have together done a lot of workshops together, and so he's disseminating the art of PCNL to several people, and this is one more attempt here that he's doing as a collective venture with friends like all of us. And the second point before I begin is I would like to pay my respects to Dr. Peter Alken, who I'm told is also listening to our webinar. He is my hero. He has been my hero ever since I started urology. And I spent time at Mainz learning a bit, and then I went to Karlsruhe where he went subsequently. And it's always a pleasure to connect with him whenever we meet internationally. So, sir, if you are listening, my respects and salute to you. So here I am telling you something, one more aspect of the complication. But before I speak anything further, all of you must realize that this is an art which S.K. Pal already said, this is an art which we eventually end up mastering. And remember always that when you are in search of honey, you must expect to be stung by the bees. So once in a while, this is going to happen. But also remember that no game was ever worth a rap for a rational man to play, into which no accident, no mishap could possibly find its way. If you play a game which is so simple, never goes wrong, where is the fun? There is no fun. So the real fun of PCNL is that sometimes it goes wrong, and we as masters of the game should identify what went wrong and should also try and correct it. And finally, for the youngsters, failure is essential. If your uniform isn't dirty, you weren't part of the game. Everybody has dirtied their uniform once in a while, and it is only when you dirty your uniform you have played the game enough. Okay, so now the topic assigned to me is infundibular narrowing. When you do PCNL, there are two vulnerable sites which can end up in some kind of a damage and eventually end up in a stricture. One site is the infundibulum, which is a relatively narrow part of the system, and if you damage it, it can narrow down further and can create a problem. And the other part is the UPJ, the uretero-pelvic junction, which again, if you do a little bit of additional damage to the tissue by laser application or by ultrasonic application, it can end up in a stricture subsequently. I'm going to talk about infundibular narrowing. Now, how does this happen? Infundibular narrowing can happen if you thrust a large amplugs through a narrow infundibulum, or if you do excessive forceps manipulation to reach a difficult stone fragment. So a little bit of tear or continuous tinkering with that infundibular zone can eventually lead to narrowing. So let me show you this case first. This was a case, a kind of a partial Staghorn. The stone was in the lower pole and a little bit in the middle calyx as well. So this was the IVU. The stone being in the lower pole, it was obstructing that infundibulum, leading to lower pole hydronephrosis, and there was a little bit of stone in the middle calyx as well. So we decided that we will puncture the lower pole and maybe bring out the entire stone and torque the telescope a little bit and also pull out this fragment. So what happened was, let me run the video. So we removed the lower pole, and that stone in the middle calyx, we were trying desperately. So I was trying to reach there, but the angle was so much that I could not reach until we decided that let me take the risk of torquing and cause bleeding. And in the process of doing that, we had tinkered a lot with the forceps at the infundibular level, which eventually led to an infundibular stenosis. Let me show you this case, and this will be shown a bit in detail, that this was a patient with a full Staghorn stone. As you can see here, this was a full Staghorn stone on the right side, a small stone on the left side as well. But let's concentrate on the right side. So this was a full Staghorn stone, as you can see, occupying the entire pelvic calyceal system. And this stone was approached by a lower pole puncture. A lower pole puncture took away all the stone, and only the upper part was remaining. And since it was not in the properly aligned, a little bit of torquing, and in the process of chasing this fragment, that fragment fell away and went further up the upper pole. It went further up, and to chase that stone, there was more torquing done, more of the scope being pushed through that narrow part in the upper pole infundibulum, as a result of which perhaps the infundibulum was damaged to a level where it subsequently ended up in a bit of narrowing. The stone was removed, a total stone clearance, as you can see, but the leak from the operating side from the track would not stop. So at the end of 8 days, a stent was put in. A stent was put in with expectation that it will drain the urine lower down and that leak would stop. The leak would not stop at the end of more than 2 weeks. So IVU, a CT scan was done. Our smart radiology colleagues produced this IVU, and different pictures. They also gave us a 3D rotational image in which you can see that the leak was happening from the side. Hello, am I audible? Yeah. So that the leak was continuing from the side, and there was no communication. There was no communication of, sorry. There was no communication of the upper pole to the main pelvic calyceal system. Because of the narrowing, the upper pole was not draining into the pelvic calyceal system. So at the end of waiting and trying to do whatever possible, that would not stop. And as a result, we finally ended up doing a partial upper pole nephrectomy. That upper pole fragment, which had to be chased, we chased it from the lower part all the way, damaging the infundibulum. Since we could not reach there, yeah, I forgot to tell you, since we could not reach there, we made a small puncture in the upper pole and pulled out that stone. As a result, that track would simply not heal because the infundibulum had narrowed. The upper pole was not communicating with the main pelvic calyceal system, and it went on leaking and leaking, which ultimately had to be corrected by partial nephrectomy. Attempt was made to go in, an attempt was made to dilate the track. A nephrostomy through and through the track was also put in, which was removed, which ultimately ended up in the stricture coming up again. So once a tight stricture at the infundibulum, it's not going to be dilated. We all know this principle from our urethra strictures also, that a tight urethral stricture, no matter how many times you dilate, it comes back again. So that is what happened to this system also. And we ended up in a partial nephrectomy. So however small a problem is, don't take it lightly. You know, these are all of you brought out some very nice videos or some your experiences of thousands of cases being done, and somewhere something went wrong by a small mistake. Small things should not be neglected, and that is what this virus is telling us. Before I end, let me tell you that the weight of this virus is 0.85 attograms. If you see that, it is 1/1,000,000th of a trillion gram. 70 billion viruses make one person sick. There are 2 million people who are sick, now actually more, but when this data was created, so the total weight of the rogue virus is just 1 gram. And the entire humankind is on its knees just by a total of 1 gram of the virus. No matter how small a problem is, don't ignore it. Be very, very careful and try to attack that situation well in time. And before, this is a meeting, which is a virtual meeting. So at the end, which normally we are expected to tinker our glasses and have bonhomie, but let's do it. This way from far up. We are all sitting far away, but cheers to everybody. Cheers to the team who did wonderful presentations today, and let us meet up in good times. So thank you once again for this opportunity to discuss this problem with all of you. Thank you.
Thank you, Dr. Janak. Thank you very much for a very lively and very lovely presentation for a difficult complication.